I'm the head of operations for Marie Curie in Yorkshire. We cover the whole of North Yorkshire, East Riding of Yorkshire, and also West Yorkshire. So our patch, I don't know whether you can see the map behind me, covers everything around from the East Coast right over towards Oldham, from Teesside down to just below Wakefield, with the exception for this little bit in the middle, which is Leeds, because they provide their own service there. I'm based at the Marie Curie Hospice in Bradford, but I also manage all the community overnight nursing service, providing end-of-life care to people in their own homes. We have lots of different services in the hospice, which outreach into community. So we have the companion service, we have our therapy service, day therapy, outpatients, and an MND support service as well. I'm a nurse by background, so I've been in end-of-life care for 30 plus years. So hopefully what I'm sharing with you is lots of experience that I've got from working with end-of-life care. I was a Macmillan nurse for 20 years, holding my own caseload, and I've worked in lots of different hospice environments and primary care as well. Today is really about what to expect when somebody's dying, but I'll probably expand on that a little bit further and talk around how do we recognise when somebody's dying and what do we do to respond to that. Just a little bit of a disclaimer for people in the group, but also for anyone watching online later, is that we do get into quite the nitty-gritty with this in terms of the symptoms and what people will experience, and everybody is different. Some people will have one symptom, some people will have none, and some people will have lots of symptoms. And I'm not sure where people are at in terms of who's joining the conversation as to what your experiences have been. But talking about end of life can be quite difficult and it can be very emotive. So, you know, feel free if you're finding it difficult to switch off. But also there's an opportunity at the end to ask any questions as well and go into more detail. I've also put some information about Marie Curie support line at the end of the presentation, so that if you do feel that you need additional support at the end of the session, we do have our online and telephone support line for you. Okay, so getting into the nitty-gritty then. So what we're going to talk about today is how do we recognise dying and how do we respond to it. So the things that I'm going to cover is why is it important? Why do we need to know when somebody is coming to the final stage of life? What are the barriers that we might have in recognising when somebody's dying? What are we going to expect to see when somebody's dying? And there's different phases of dying. So what are the different phases and what are we going to see in those different phases? And then what are we going to do about it? So how are we going to support the person themselves and also the family and friends around them and the people that are important to them? First of all, why is it important? And I think, you know, anyone that's joined this has already got that common understanding that recognising and caring for people at end of life is really important. But just simple things is that it's a really powerful source of emotional turmoil. People become really socially isolated and people can experience existential crisis or spiritual distress. So it's our role really to support people as much as possible, so that they're not going through that alone, and also that we can manage the symptoms as much as possible. With lots of expert palliative care resources around, people don't always know how to access that support or have that support come in when you need it. So it's about signposting to different support services that are available to them and make sure that there's no misguided clinical interventions, that people are treated appropriately at end of life. Lots of people's complaints that come back around when we meet people for the first time in Marie Curie is often around some of the poor experiences that they've had with hospital treatments, possibly not being managed with their symptoms adequately prior to specialist palliative care services and end-of-life care services becoming involved. We need to know what people's life expectancy is, because people have things to do and people have things that they want to achieve. So if we have an idea of of what phase people are in within their disease progression, whatever that might be. It gives them the opportunity to plan ahead, to express their wishes, and to involve the people around them that they want to involve. And making sure that somebody has a comfortable, dignified death, whatever that means to them. And it's not about us deciding what that is for them, it's then having that control and that ability to share with people what their wishes are for the future. So a lot of what we're doing is around maintaining control, helping people to plan and express their wishes, ensuring that appropriate care and support are available to them, making sure they're treated with dignity and respect, and importantly is also supporting the person to die in their preferred place. That sometimes can change towards the end of life and in the last days as people struggle either with carer strain or also with symptoms, but trying wherever we can to help people to die in their preferred place of care, to manage their symptoms, pain and prevent any distress, and help people to say goodbye, express how they feel and manage any unfinished business. And it's allowing people to have that access to emotional, spiritual support when needed, and supporting the family and those close to the person. We had a publication that came out a few years ago called One Chance to Get It Right, which was very much focused on how do we support people at end of life. And they identified 5 priorities of dying. The first one was recognising, which is what we're going to talk about today. Once we've recognised that somebody's dying, it's then about having that really sensitive communication between the staff that are caring for the person, the dying person themselves, which was often the person that was left out of the loop, and also the family around them. And that means involving that person themselves in as much as they want to be involved in that decision around treatment and around care and around how they want to be supported, providing the support that they need, and then planning and doing it. So once we've made a plan with the person and involved them, we then put that plan into action. So we're always working within those 5 priorities of care for the dying. But we know there's lots of barriers to recognising when somebody is dying, and then that makes it difficult for us to respond. So certainly the barrier for recognising is that people don't always follow the plan. And I'll come on a bit more about that in a minute. Sometimes we fail to recognise the signs and symptoms, and unless you're aware of what you're looking for, it can make it difficult to decide, is somebody dying, or are they acutely unwell, or are they just not feeling tired today? So having an idea of what all the symptoms are and what to look out for can help it to recognise. People sometimes have sudden changes as well. So for example, somebody might have a cancer diagnosis, but that doesn't mean that they won't have a stroke or a heart attack. You know, sometimes things happen suddenly that we're not aware of and we can't plan for, which again makes it really difficult to recognise. Sometimes people think that there might be something that can be reversible, and what we will always do is try and reverse any reversible causes as much as we possibly can. So for example, somebody might have a chest infection, and if they are responsive to antibiotics and that's what they want, then we would always offer treatment for that. Sometimes people don't respond to infections at the end of life, and at that point we have to make that discussion and have those conversations about, is that the right thing to do? And people can die of different causes. You know, lots of different ways that people die can also help us to think about, how are we going to recognise this? You know, everybody dies in different ways. And then we also have the barriers for caring for somebody. And some of that might be lack of knowledge of what to do. We know we need to do something, but we don't know what to do. And that can lead on to sometimes the need to do something. And certainly when I worked in a hospital many years ago, some of the time the medical staff would treat people with chemotherapy or antibiotics right up until the day before they died, because they felt they needed to do something. So it's about us making sure that the need to do something is doing the right thing by managing the symptoms, by recognising what we need to do. There might also be a fear of communicating with the patient and the family. It's not easy to talk to somebody and tell somebody that they're dying. So sometimes that fear of having that conversation can make it difficult to respond. There's also sometimes a fear of shortening life, when we're using different medications to manage symptoms, people often have a worry that that might hasten death. And often the case is that it doesn't. What it does is manage the symptoms and the person's already dying. And there's some concerns around stopping treatment as well. So if we stop these antibiotics, is that going to speed up death? We would only do that if at that point we were seeing no response to the antibiotics at all. I hope that's making sense so far. I think coming on to sort of some of the stats, these are from the leading causes of death in England and Wales from 2022. And this was the first time in a couple of years that COVID dropped down from the #1 cause of death. But what we can see is that Alzheimer's and dementia are now the leading cause of death in England and Wales. Ischemic heart disease, so people with heart failure, heart attacks, comes very close second. And then we've got respiratory disease coming as third, and cerebral vascular disease, which is strokes, fourth down on the list. And then lung cancer or cancer of the respiratory system comes down on the 5th of the list. So actually what we're seeing is a big turnaround from coronavirus and cancer being leading causes of death to actually being Alzheimer and dementia, which can be very difficult to predict. So just to share with you really about why it's difficult is that we have what we call different disease trajectories. So the first one, the top line, the blue line, is trajectory 1, and that's somebody that has a cancer diagnosis. And often what you will find is that while they're having active treatment, they can be quite stable and things go along quite nicely until the point where the treatment isn't working anymore, and then treatment is stopped. And then people can have quite a sudden decline, and that the end of life stage then can come quite quickly. But we're often very aware of that's going to happen, because the oncologist will have had those conversations at the point of stopping treatment, that this is the point where we're moving into palliative stage now. Disease trajectory 2 is organ failure. So we're talking about heart failure, liver failure, renal failure, and respiratory disease, so chronic obstructive airways disease, heart failure. And this is more difficult because people have more of a long, slow, steady decline. And then they might have acute periods of illness where they become very unwell and possibly need a hospital admission. And each time they go into hospital, what you find is that when they come out, they're not quite as well as they were when they went in. And this can happen several times up until the point where the treatment that they have in hospital is no longer working and they come towards end of life. And actually, sometimes it looks a bit like a practice run at dying. And at any point in this, we could think that people are coming towards the end of life, and then they respond suddenly to treatment and are a bit better. But what we find is certainly in the last year of life is that people have multiple hospital admissions, multiple exacerbations of their disease. And then the last one is dementia and frailty, where people have a very, very long, slow progression of their illness, and this can take often very, very long periods of time, and often years, where people have a low level of functioning and they're very poorly for a long time. And that can be very, very difficult to predict when somebody is coming towards the end of life, when they have a dementia or a frailty diagnosis. But what we do see is that there is often changes when somebody is coming towards the end of the life. And these changes happen because the body is slowing down, and it shows us signs that they're approaching the end of life. Not everyone will have symptoms, and the symptoms can be caused by other things, particularly if people have one or more things happening to them. And not everybody just has one single diagnosis. There might be somebody with a cancer diagnosis, with heart failure, with chronic obstructive disease as well. And often what we see is that there's a decline of all of them at the same time. What we can find is that the symptoms that somebody experiences do depend on the illnesses that they have, and also the general health and well-being that they've had previously, and any treatments that they've had recently, which makes it quite difficult to predict what will happen. But knowing what the possibilities are, make it easier for us to plan ahead and to prepare for what we might see in the future. So certainly what I'm going to talk about more is around the last weeks of life. and also the last days of life here, which we call the pre-active phase and the active phase. Some people might have heard those talked about previously, but we're certainly talking about sort of 2 to 3, 4 weeks of life, and then the last 2 to 3 days of life. And what we'll touch on is sort of the physical, emotional, social and spiritual signs that you might actually see. So in the pre-active phase, we might have weight loss, increased swelling, water retention, feeling weak and sleeping, increased fatigue and needing more rest periods, changes of body temperature, feeling hot and cold, loss of appetite, decreased intake of food and fluid, bladder and bowel problems, and inability to heal from wounds or infections. I'm going to go into these some of these in a bit more detail in a moment. Some of the other signs of pre-active phase are that people might withdraw from social activity. They might talk less, and they might have a loss of interest in normal activities. They might be unable to get out of bed because of weakness and tiredness. They also might start talking about seeing people that have already died that have come to talk to them, that have come to see them. And that can be quite disconcerting for everybody else around the person that's dying. They might have spiritual requests or concerns, and they might want to talk about death and dying. They might have requests from to their family to help settle unfinished business, tie up any loose ends, or also possibly to speak to people that might not have spoken to for a long time and mend relationships. But there's also common symptoms that people might experience of pain, nausea and vomiting, breathlessness, and that can result in the need for medication changes. Then we have the active phase, which is where people come towards the very last stages of their life, and this might be the last hours to the last few days of life. People might become unresponsive or have very limited response. They may become more restless and agitated and have hallucinations. They might become quite confused and have delirium, which is a sudden onset of confusion. And you will certainly see changes in breathing patterns. Sometimes there will develop respiratory congestion and secretions, which often people refer to as a death rattle. And it may be that they have an inability to swallow fluids. Again, the person may say, "I'm dying," because often people are very acutely aware of what that process is themselves and how they feel. Sometimes speech can be very difficult and people just don't have the ability to talk because they're so weak, but often they still can hear us, and we would talk to somebody always as if they could hear everything that we said. They may experience bladder and bowel incontinence, or they may have a marked decrease in their urinary output, so they start peeing much less and they don't have as much fluid in their bladder. They can become confused about time or day, or also not recognise the people that are around them. They might have reduced hearing and vision, and sometimes in the very, very final stages of life, people can develop a fixed stare, so that they're not really looking at anything around them and they're not able to focus on individuals. You might feel some hand and feet coldness when you touch them, and you can get colour changes in lips, hands and legs, especially the feet and hands. And that colour change will depend upon the ethnicity of the person. So certainly if it was somebody that was white, you might see a blue tinge, but if it was somebody of darker skin colour, you might see some darkened skin colours, and often you will see a paleness and gums instead, and mucous membranes. So what can we do when we recognise that somebody is dying? I think the most important thing is having that open and honest and sensitive conversation with the person themselves and also everyone around them about the changes in the condition and the deterioration and what that means for them. Discussing what might happen, what to expect, and include the common signs and symptoms that they might experience, which will alleviate fear. The feedback that we often get is when somebody has an experience of a symptom that's common, but they weren't expecting it, and that can cause a lot of distress. So pre-warning people what they might experience by doing something similar to this can help them to be prepared and then know what's normal and what's not normal, and therefore what they need help for and what they might need to manage themselves or with the support around them. Ensure how the family know how to contact people for support, both during the day but also out of hours as well. And it's often in the small hours of the morning when somebody's distressed that people panic the most and become the most fearful and anxious, because they don't know who to contact in the middle of the night when they're on their own. So knowing who that they can contact and have numbers for them available is really helpful. Listening to them and establishing what their wishes are, which will include what their preferred place of death is. And most people do prefer to die at home, but it's not always practical. So what is another opportunity for people to, where do they want to die? Do they want hospice care? Do they want to be in hospital? Or actually, do they want to be in a care home facility? And trying to make that happen if possible. Planning and providing that person-centred care. Every single person is different and everybody will want individualised care. So making sure that we make it bespoke to that individual. Managing their symptoms effectively is really important. I think most people will know somebody, if not somebody they know personally, that has had an experience at end of life that's been distressing. So what we want to do is try and avoid that as much as possible and leave the people that are bereaved with a really positive experience so that they can know full well that their relative or their loved one has died with dignity and respect and with their symptoms managed and not with any distress at all. And then also provide ongoing support throughout the whole end of life experience and also into bereavement if required. As a healthcare team, our roles are a little bit different to that. So making sure that we communicate and collaborate with the healthcare team and social care teams around us. And again, making sure that the teams out of hours are aware that the person is entering the last days of life so that they can be prepared to respond quickly if they need to. Making sure that we've got the as and when medications there to manage the symptoms that people might experience, and also the equipment. So we do have times where the medication has been provided, it's in the person's house, but actually we don't have any needles and syringes to give an injection. So making sure that everything is provided and we're looking at everything that's needed. That any pain or symptoms or distress are managed immediately, and that we report any changes back to the healthcare team that are looking after them. Rationalise any regular medications. So people that are on medications to prevent problems often don't need those in the last days of life. And people may struggle to take oral medications anyway. So converting any medications that we need to a syringe driver or injection form or even patches if we need to. Sorry, I'm talking, I'm going to have a drink. So planning and organising the support that they need, and also ensuring the whole team are aware of the management plan. So there's no point in one team thinking that the person's going to die at home and somebody else says, well, actually, no, they want to go into the hospice. So we have to provide different care. Everyone needs to know what the plan is. And it's really important that we know what the plan is so that we can avoid crisis. And some people might have an internal cardiac defibrillator. And when they're at the end of life, it's really important to turn that off. Sorry, I'm getting a tickle.
Annette, don't stress, take your time, don't worry. We can pause it if you want to.
That's okay. And we also need to make sure that we review their resuscitation status. What we don't want to do is resuscitate somebody at the very end of life when we know it's a natural process of dying, because it won't be effective and it will cause a lot of distress. So making sure that we do review that and that we have the opportunity for advanced care planning discussions, and also to make sure that the person's wishes are documented. Okay, so I have put a video in there, and actually with my voice going, it might be a good opportunity to actually show this video, and then we can come on to a bit more common symptoms in a minute. Oh, can you hear it? Can you actually hear that?
No, do you want to just try again?
I'm going to talk about.
Yeah.
You can, lovely.
Days and hours of life. It can be reassuring and helpful to know what to expect. There are some common signs that you might see when someone is dying. Not everyone has these, and some people may only have one or two. Some of the signs are caused by the body slowing down. Others might be caused by illness or treatment. It's important to remember that everyone is different. We can't predict exactly what will happen in someone's last weeks, days, or hours of life. In the last weeks of life, some people become more weak or tired and may need to sleep more. They might be less able to have conversations or seem less like their usual self. Many people will eat and drink less. The body is slowing down and using less energy, so they don't need so much food or drink. Some people lose weight and muscle and look thin and frail.
During the final weeks of Simon's life, he became less mobile. He had problems with his knees and couldn't walk. So we had to go into the hospital bed downstairs in the house.
During the last few weeks, we noticed that her energy levels were definitely going down. She was beginning to sleep a lot, and I would say she began to distance herself gradually from her family and wanted a long quiet time by herself.
She certainly started sleeping very much more, maybe 18 hours a day. And obviously, we just let that happen. We didn't try and sort of force her to stay awake from it, because that was obviously what her body needed with that storage.
In the last days of someone's life, some people feel restless or agitated and find it difficult to feel comfortable and relaxed. Some people may have physical symptoms like a sore or dry mouth, feeling sick, or experiencing pain. Some people might be confused or seem disorientated. Some may feel breathless or short of breath.
The breathlessness that she had was very much caused by the pneumonia and the damage to her lungs, which may not be the case with every disease. But certainly that breathlessness was something that carried on for the last 4 months. One of the other symptoms of the chemotherapy was that it causes a lot of mouth watering. So she was in some distress from that, and that's why she liked all these cool, smooth liquids, just to help her keep it.
There was what the medical people call agitation. For me and my brother and my dad, it was quite uncomfortable to watch because we'd never seen my mum in that way. Doctors explained to me that that was normal for somebody who was terminally ill. Agitation, things like arms flailing. Sometimes there's a crying noise that was coming from mum, which was very unfamiliar for us as her children. So there were times that as a carer I felt like that I wasn't doing okay. A person may lose control of their bladder or bowels as their muscles relax. Skin might look slightly blue or become mottled and feel cold to touch. Some people have noisy breathing. This can happen if mucus has built up in someone's throat or airways and they aren't able to cough or clear their airways. Breathing may slow down and become irregular. It might stop and then start, or there might be pauses or stops between breaths. The person might lose consciousness, but they may still have some awareness of other people in the room.
He didn't have any control over his bladder or his bowel, so he had a catheter fitted, and then he was padded for his bowels, which I looked after him. I washed him, cared for him that way as well.
Her breathing changed. So initially, her breathing was quite deep, and then there's a kind of raspiness to her breathing that becomes a little bit more shallow.
I noticed that his breathing had started to rasp, and his colour in his face had changed from a yellowy colour to a grey tinge. Towards the end, Simon lost consciousness a day and a half, and he never came round again. It was a slow deterioration.
The colour of her skin was very, very pale. And then in the final hours, I noticed that her lips were becoming blue.
It was very peaceful, it was very quiet. My son and daughter were with her as I was. I think one of the cats was on her bed, and she actually breathed her last in her own home, which, when you're looking for crumbs of comfort, is something you'll appreciate.
The doctor or nurse will focus on making the person as comfortable as possible. Some of the signs I've talked about can be managed or treated. The doctor or nurse might give the person medicines or suggest ways to help them. If you do notice that your loved one is distressed, confused, or in pain, speak to their doctor or nurse. If you're with the person who's dying, it might be reassuring if you sit with them. Speak calmly to them and hold their hand. This might be a really difficult time for you. You might have a lot going on and be worried about the future. It's important to be kind to yourself.
Until you actually see it and witness it and think this is it. If you're not prepared. I wish that I'd have taken some more help for people to come.
Arm yourself with as much knowledge as possible. For me, it was having practical knowledge, where the GP had those conversations with us, where he gave us a steer on what was coming down the track.
Looking back, one of the things I realised is that I ended up getting involved in certain tasks, certain feelings that were new to me. And some of them were quite challenging, but I think when your motivation is to make a very bad situation as good as it can be, it's amazing what you can achieve.
When I first knew what was going to happen, you think you can't cope. You think there's no way, how am I going to deal with this? But somewhere inside you get an inner strength and you can deal with anything. It's hard, it's heartbreaking. And after the inevitable happens, that's when you fall apart, which is what I did. But you will cope with it, you will deal with it, and just take help where you can.
Okay, so I'm not going to go into lots of detail about each of the symptoms, but I hope that's just giving you a bit of an idea about what some of the people will experience and certainly how that leaves families feeling afterwards. As we say, that loss of consciousness, often people will be able to hear what's being said in the room, so it's important that we acknowledge that they're there and we talk to them directly. And certainly what we would do is always explain everything that we're going to do for the person, so that they're aware. And sometimes people will flinch if you touch them before you've told them what you're going to do. So if you say, I'm just going to hold your hand as you go to hold the hands, they're aware of what's going to happen next. We talked a bit about changes to skin and the limbs and hands and feet feeling cooler, and that's mainly because of the blood circulation slowing down in the body. People with lighter skin, like we said, can have that blue mottling colour, but people with darker skin tones, blue can be really hard to see. So it's easier to see on lips, nose, cheeks, ears, and also tongue, and also inside the mouth. And mottling is also harder to see on darker tones. So their skin may look darker than normal, it might look purple or brownish in colour. I think the most distressing symptom that a lot of people talk about is the noisy breathing. when the breathing can be very loud and noisy, as if mucus is building up in the back of the airways. On an average day, most people swallow about 1.5 litres of saliva that the body is making, and that continues at the end of life as well. And if somebody is unable to swallow, a lot of that saliva will build in the back of the throat, and it's very difficult to actually manage that. The most important thing is making sure that somebody is in a position where they can drain that secretions naturally. Medications can be given to help dry the secretions, but again, that medication can then lead to a dry mouth. What I often say to people is that the noisy breathing is a bit like snoring, is that everybody else in the room can be distressed by it, but the person themselves is unaware, and often they are already unconscious and not aware that their breathing is noisy at all, and it's unlikely to be distressing for that person themselves. Shallow and irregular breathing is quite common at the very end of life, where people will have pauses in their breathing and their breathing becomes very irregular. And this can sometimes be known as Cheyne-Stokes breathing, where people will stop breathing for periods of time. The breathing pattern may actually lengthen so that they will breathe and then they will have a very long gap and then breathe and a very long gap. And sometimes people in those gaps think that somebody's passed away, and at some point when they do die, then their breathing will stop altogether, but the gaps will get longer and longer in between. Like we said before around family and friends, what can they do? Reassuring the person, speaking calmly to them, holding their hands or stroking them. Even if someone's unconscious, they might still be able to hear you, so having a conversation with them, let them know what's happening in the family, reassuring them. And if you're worried that they're distressed or in any pain, making sure that you escalate that to the doctor or nurses that are looking after them so that they can prescribe and administer any medications they need to keep them comfortable. If you're alone with the person and would like somebody with you when they die afterwards, you can also call friends or family, or even sometimes asking the district nurse to refer to Marie Curie. We can provide night support for people. As health professionals, what can we do? I think that it's really important to acknowledge that if there is a delay between recognising dying, acknowledging when somebody's entering that dying phase, and actually dealing with that or inappropriately managing the symptoms, it can lead to distress. So that recognition, acknowledgement and support have to be quite rapid, and we need to do that quite quickly to make sure that the person and those supporting them are involved and the symptoms are managed in a sensitive way. The most common symptoms that we see at end of life are pain, nausea and vomiting, restlessness, agitation and distress, respiratory secretions, dry mouth and breathlessness. And the medication that is provided will manage all of these different symptoms, and it's often called anticipatory medications or as and when medications. And when somebody is entering the final stages of life, the GP will prescribe these medications so that the person has them in their house ready to be administered, so that there isn't a delay in the middle of the night or on weekends in getting medication that the person might need. There's lots of ways that we can manage people in terms of their pain and symptoms, and often they're the same way that we manage each one. So making sure that the person is able to take their medications as prescribed, monitoring their side effects or effects of them. If they can't take them by tablet anymore, converting them into either a syringe driver or injection or patch form. If the pain and symptoms are not responding to the treatment, making sure that the doctors are aware of that so they can review the medication, providing explanations, reassurance and support. And if somebody does have a syringe driver and there's any problems with it, making sure that the district nursing team, or if they're in a hospital or in a hospice, the nursing team are aware that there's a problem so they can manage that. But it's also important we look at non-drug therapies as well. And somebody that's in pain, it might be that they need a massage or stroking of an area. It might be that their position needs changing, or they might need that limb or even sitting up a little bit. And we can also use heat pads or cold pads to try and manage that pain for them. But helping the person to find a really comfortable position so that they can rest is most important. Again, people might experience nausea and vomiting. And as you can see, the top 3 slides are exactly the same. It's about supporting medication, escalating if the symptoms get worse, and providing explanations. But we also might want to support people with really small portions of bland food. Certainly things that are highly spiced or fatty can make the nausea and vomiting worse. So just what people want, and the need for food and fluid will certainly decrease towards the end of life as they don't need that amount. Offering ice drinks, ice chips, fruit juices, ice lollies, just to maintain hydration is really good. And having cool air circulating in the room, or a window or a fan, can help people feel much better. Certainly I suffer from travel sickness, and the first thing I do when I feel sick is open the car window. And it's the same kind of thing. Making sure somebody feels cool can really help to alleviate any nausea and vomiting. And also avoiding offensive smells. Sometimes if there's somebody got a very strong perfume on, that can make people feel more nauseous. Cooking smells from the kitchen, so ensuring the door's shut if possible, or also bathroom smells. If they've got a commode that's been used at the side of the bed, that can make people feel quite sickly as well. So as and when we can, emptying them as quickly as possible to remove any smells that are around. I think one of the most distressing symptoms, again, as well as the noisy breathing, is restlessness and agitation and distress. And often there are reversible causes for this. So sometimes people can't pass urine, the bladder's not working correctly, so they might need support with a catheter to try and help them. We're conditioned from a very, very tiny age, aren't we, that we don't wee or poo in the bed. And people will always have that, even when they're unconscious. So often they will try and get out of bed when they're agitated to go to the bathroom. So helping them with that and reassuring them that it's okay, they've got a bedpan, they've got a pad, or they've got a catheter to pass urine or to open their bowels can help to settle the agitation. People might have struggle with constipation as well, and they might need bowel care. There might be pain, discomfort, delirium. So managing all their symptoms can help to settle the agitation as well. But we also have to be aware of people that might have been a heavy smoker, for example, and in the last days of life when they're not able to have a cigarette, they might need nicotine patches just to help with the withdrawal. Or it might be that they're having spiritual or psychological distress, and they might be waiting for a particular person to come and see them, or even in fact somebody to leave them when they're at the end of life, because they don't want that person to be there when they're dying, as they don't want to cause distress. So we would always provide a really reassuring, calm environment for both the patient and the family as where we can. Support with medications to settle them if possible, to reduce anxiety. And most importantly is making sure that the person's safe. What we don't want is anyone to fall out of bed or fall because they're agitated, and then that might result in a hospital admission at the end of life that we absolutely wouldn't want. Making sure that if the medications or the way that we're managing isn't working, that we escalate that to the medical team that are looking after them to try and manage those symptoms. And sometimes just some relaxing touch, just holding hands, just speaking calmly to somebody. It might be that some calming music or some aromatherapy oils in the room can help to calm somebody as well. So there's lots we can do without medication to help calm someone. We've talked a little bit about the secretions already. If somebody does have that nasty secretions, or the death rattle as people call it, sitting somebody up slightly in bed, so using pillows to prop them up at a 30-degree angle, can help the secretions to drain. Making sure somebody's laid on their side and moving people from side to side can help, but somebody laid flat and on their back will actually encourage the secretions to pool more. What we don't find is that suction helps. People often think it needs to be sucked away with a suction machine, but what happens is the body will naturally fill any spaces. So as we suck that away, it will just collect even more and can actually increase the secretions rather than reduce them. Again, there's medications that can help, but often they don't take the secretions away completely. So when we do give medications, reassuring the family that they will help to prevent them get worse, but often won't take them away completely. And the medications can provide somebody with a really dry mouth, so making sure that they have good mouth care as well is really important. I'm not going to go into details around mouth care. but making sure that the mouth is moist all of the time. We can use soft toothbrushes, we can use lip balm to just make sure that the teeth are, the lips are smooth. Breathlessness can be a problem, and again, having a cool environment, having fan therapy around them, having a fan circulating air can help people to settle from a breathing point of view. Again, a lot of the problem with breathlessness can be that the person is feeling breathless, so they become anxious. And then because they're anxious, they hyperventilate, and then they can become more breathless. So we have to tackle the anxiety and the breathlessness at the same time with different medications. There's lots of different medications that we can use at end of life, far too many for me to go into, but I have listed a few of them on the slides so that when the slides are shared with you, you can see what some of the medications are and what some of them are for. At the moment of death, it's not always clear when that actual moment will occur, and the doctor or healthcare professional will confirm death if breathing, heart and circulation has stopped, if they're in a medical environment. If they're at home, you may notice that they've stopped breathing and they're not able to respond at all. And it's important that you would ring somebody out of hours, like a district nurse or the GP, to come out and see the person just to verify that death has occurred. They will notice that the person themselves seem more relaxed, their face will often soften and they will look peaceful. And it's unlikely that the person is unaware themselves at that moment that they are dying themselves, especially if there is any distress. Often the people are already deeply unconscious at that point and won't be aware of it. People sometimes have different beliefs about what happens after death, and it's really important that we acknowledge that and manage the cultural beliefs at that point. Often people will choose the moment when they die, and certainly my experience as a nurse of 30 plus years, I've seen many people waiting for somebody to come and see them at the end of their life before they'll pass away. I've also noticed that people sometimes will be with them 24 hours a day, 7 days a week, and that moment that person nips off for a shower or goes to the toilet, the person dies, and it means that that person themselves are often waiting because they don't want to cause additional distress to that person. So reassuring the person, the family around them, that actually the person themselves will often choose that moment that they want to die and who they want with them at that point in time. But being able to give everybody the opportunity to say goodbye is really important, even if that's just popping in for 5 minutes and then leaving again. When somebody has died, obviously if you're in a hospital or hospice, that's much easier because a health professional will manage that. But if you're at home and in community, it's about ringing the out of hours GP or the district nurse to be able to come and verify. And then if you're already aware of which funeral directors you're going to be using, contacting them, and they will talk through the next process. And I know that's certainly what Full Circle do, is that they will give all the information that you need when you contact them about what's going to happen next. Just a little bit about Marie Curie I've put on the end there. What we do know is that only about 1 in 4 people that die will get the support that they need. So certainly Marie Curie have got a really ambitious plan over the next 5 years that we're going to try and reach as many people as we can. We're campaigning a lot to government to try and increase funding for end-of-life services, and I've put a bit more information about that on there. But the most important thing really is the Marie Curie support line. So I've put the details about the Marie Curie support line on the end of the slides there, so that you have access to that. And they're available for clinical information, so they can help clinicians with support. They can help with emotional support for people that are living or caring for somebody with a terminal illness, and also for bereavement support and befriending as well. So if you do need to contact somebody and you're not sure who to turn to, then Marie Curie are available, and the times that the services there are on the screen. You can actually click on the links in the presentation and that will take you to those pages on the website. And if you don't feel comfortable talking to somebody over the telephone or struggle with the telephone, you can actually do that online chat as well.